everyone. My name is Mina Nabavi, and I'm a program manager with the UAB CounterACT Research Center of Excellence in Arsenicals. Welcome to today's Grand Rounds seminar. For those of you not familiar with our center, it is led by Dr. Mohammed Athar, and the goal of the center is to develop mechanism-based, highly effective medical countermeasures against arsenical chemical warfare agents. Our next virtual Grand Round seminar will take place on Thursday, February 18th at 12 p.m. noon. Mr. Terry Tincher will be our speaker. Mr. Tincher works with the Tracking, Radiation, Chemical, and Environmental Epidemiology branch at CDC. We will be sending more information about this seminar after the first of the year, but please go ahead and hold this date on your calendar. For those of you involved with the NIH CounterACT program, please remember to save the date for the next NIH CounterACT Symposium, which will be held December 6th through the 8th of 2021. The UAB Research Center of Excellence in Arsenicals will be hosting NIH's annual CounterACT Research Symposium in New Orleans, Louisiana. For more information on the center or its activities, please visit our website at uab.edu/arsenicals, or you can send us an email at as33@uab.edu. On our website, you will find links to recordings of past Grand Round seminars and our podcast. So let me introduce our speaker. Dr. William Rushton is an associate professor practicing emergency medicine and medical toxicology at UAB. He received his Doctor of Medicine from Georgetown University and pursued residency in emergency medicine, where he was chief resident, and received a fellowship for medical toxicology at the University of Virginia Medical Center. He is board certified in medical toxicology and has published on trends in toxicology, including changing patterns of drug abuse, limits in testing, and approaches to managing the intoxicated patient. As part of the CounterACT Center, Dr. Rushton has the responsibility of developing educational content and medical scenarios for clinical practicums targeting UAB undergraduate and medical students. Through his existing roles and responsibilities with the UAB residency training program, Dr. Rushton oversaw specialized training and clinical activities of our medical toxicology fellow, Dr. Doug Wallace, who presented last month's Grand Rounds. Dr. Rushton currently serves as the director of the Office of Medical Toxicology and is the medical director of the Alabama Poison Information Center at Children's of Alabama. Given all of these activities, Dr. Rushton recognizes the importance of teaching the next generation and has taught introduction of medical toxicology since 2016. Dr. Rushton, thank you so much for being here and joining us today. I will stop sharing my slides and you can begin sharing on your end.
So I want to say thank you to everyone for having me. Really, what an honor it is to be here. And this is actually particularly exciting for me because last year I was given the opportunity to talk about the history of arsenic poisoning and where we are with arsenic poisoning. And I had such a good time and got just really excited about that opportunity to talk to you guys. I know I've been pestering sort of the education component to bring me back. And this time, I actually really wanted to focus in on thallium and organic mercury poisoning. And really, my goal in this talk is just try to share some of the enthusiasm, if not the excitement I have really with this topic, and hopefully keep people sort of, at least awake, if not entertained, throughout the course of this talk here. And Mina, actually, when you started talking about the CounterACT mission statement, I was furiously trying to wave at you because that's perfect, sort of the perfect introduction to my talk. And because this is sort of what Mina was saying about, the goal of this center, which is unbelievably important, is really about developing mechanisms against arsenical chemicals that are out there, particularly, mass exposures, doing, bench research as well as education. And when you think about that is, well, where does thallium and organic mercury poisoning come into that? Because clearly these are not arsenical-based compounds. The reason that I'm so intrigued about this and why I think this fits in so well at the center, and I'm going to spend the next 5 to 7 hours. I'm just kidding. I promise everyone I'd keep it to 45 minutes. But the next 45 minutes really telling everyone about there's a lot of overlap in the constellation of symptoms. And when you're considering arsenic poisoning or arsenical poisoning, I think it's also helpful to consider thallium and potentially organic mercury poisoning. Because if you don't consider it and you don't order the correct ancillary studies, it can be very easy to miss these sort of metals that have a lot of overlap, both with the mechanism and even with sort of the clinical picture with arsenicals that goes out there. And this is sort of a way, if we think we're dealing with arsenicals, not just to keep, our blinders on, but to continue to expand upon sort of developing an extensive differential diagnosis. And so we're going to talk about some of the mass exposures out there with thallium and organic mercury, sort of understand the dangers, particularly talk about the complications and challenges and identification of these type of poisonings, and review clues to diagnose and treatment modalities. And before I go any further, I did sort of want to frame my topic with this slide right here. Because if you're considering heavy metal poisoning, at most institutions, and absolutely at the University of Alabama, Birmingham, if you order a heavy metal screen, this is what you're getting. This is a 24-hour urine test. And what you're going to get is urine arsenic, urine lead, urine cadmium, and urine mercury. Just because I'm trying not to give sort of any commercial bias, I did block out the name of this company up here. But as we go through this talk and I sort of talk about thallium and organic mercury poisoning, understand our limitations, that even if we put heavy metals on a diagnosis or a differential, whether it's one singular patient showing up to our healthcare institution, or whether we're seeing cluster of patients coming in with these sort of unique symptoms, just understand that if you order just a heavy metal screen, exactly what that is. And we're going to actually come back to this slide at the very end of my talk. Really was sort of when I try to identify the pitfalls in heavy metal poisoning, particularly with thallium and potentially organic mercury poisoning. And I don't know how often I get to say the word thalatoxicosis as much as possible. So I made this my initial slider out here. I have a medical toxicology course. I've been talking to them pretty excitedly about this talk, and we've talked a lot about thalatoxicosis. And I just don't know if there's many fascinating diagnoses that have such sort of a unique or somewhat esoteric name. But the history of thallium poisoning, just like with arsenic poisoning, is really interesting. It's actually showed up a lot in literature. Agatha Christie in The Pale Horse. And here, sort of the main sort of culprit in here is actually poisoning the protagonist with thallium, and one of the initial symptoms here, which is how they eventually put together severe alopecia, which means sort of hair falling out. And then in Young Poisoner's Handbook, which was initially a book that was written, and then eventually actually became a really fascinating movie here, is this is actually sort of based on the true life story of this young adolescent that actually poisoned his stepmother and then eventually got caught and poisoned several other people with thallium that's out there. But unfortunately, thallium does have this potential for being used for insidious uses on a much more mass exposure, mass casualty type of scare. If you put in thallium right now into your usual news search, you'll come up with several of these sort of news articles that are out there. This top one is actually coming from Newsweek, talking about how ISIS has actually obtained, or at least we were concerned they obtained, several sort of vats of thallium with the idea of contaminating, the Western world's food source, and potentially sort of prisoners as well as the bottom sort of news article actually comes out of Indian news publication, also really just warning of ISIS and their sort of desire to sort of obtain thallium, just sort of used as a mass casualty chemical exposure. This is actually a WHO report from 2008 that's really sort of warning about these Iraqi families that were showing up with thallium poisoning, and sort of this warning out there. What's really fascinating about this is our own Ziad Qazi, who I believe is actually a participant in this conference today, is actually one of the foremost international experts on thallium poisoning, particularly with these Iraqi cases. And Dr. Causey actually published this report in last year, one of our toxicology conferences. And this is really focusing on the state of affairs of 67 Iraqi families that were all sort of giving thallium poisoning for homicidal or sort of malicious intent. And what's really interesting is what he found in this report that he published out there is by far the most common sort of symptom among everyone was actually severe neurotoxicity, usually identified as severe painful neuropathy, which we're going to get into. Now, thallium, it's just not showing up in historical, it's not showing up in fiction with Agatha Christie. It's not just a problem that, is unique to outside the United States, but actually has been popping up even these mass exposures within the United States. And this is actually a manuscript that got published in 2002. It's called Thallium in a Small Midwestern Town. This is actually, the senior author of this was Mark Kirk, who I had the opportunity to train under. And several years ago, I was lucky enough to actually sort of pick his brain about this. But the title of their manuscript was actually, this could also be sort of a Agatha Christie novel right here, talking about sort of the dangerous small Midwestern town. But I did actually want to go through this about, sort of some of the challenges and set us up for some of the challenges in identification of thallium poisoning. Because this is a 58-year-old male that showed up to a healthcare facility. And the parts I really care about, I put in bold here, but he really came with this deep burning, really with his lower extremities, and extensively tender to the touch. Went into the local emergency department, we sort of getting this diagnosis of a nonspecific neuropathy, admitted. Initial workup, very unremarkable. Got some nerve conduction studies, which showed this peripheral neuropathy. And then what they did, they were sort of really scratching their heads, thinking about what this could be. And he got the diagnosis of alcoholic peripheral neuropathy. And then he got discharged home really on pain medicine with sort of the recommendation to take multivitamins and to cut down on his ethanol intake. And why am I so fascinated by this? Well, this is such a fallacy, I think, when it comes to heavy metal poisoning. In that last year when I had the opportunity to talk to the Center about arsenical poisoning, I focused a lot on this report on the Staffordshire beer epidemic from 1900. And Kilmackey and Kirby actually went through this 1900 arsenic exposure. And what's really fascinating about this is sort of the initial misdiagnosis of alcoholic peripheral neuropathy. And it's interesting that it seems to pop up repeatedly, I think, with a lot of heavy metal poisoning. So not just with arsenicals, but also with thallium, not really sort of expanding upon an initial differential diagnosis. But the story that happened that they published in 2002 out of Indiana University is just really fascinating, because what happened after this initial guy came in is 11 other coworkers then showed up with similar symptoms. And what I'm very proud about this is it was actually the Regional Poison Center that put this together. I'm the medical director for the Alabama Poison Information Center. And so as much sort of, positive poison center, news, good juju we could put out there as possible. But this is, I'm going to end, is one of the benefits of, reporting groups such as Poison Center, state health departments. But really the constellation of symptoms are put together by the Poison Center. And what they realized is multiple of these people had decreased proprioceptions, vibration. And on the basis of all this is they ordered a heavy metal screen, and several of the people actually came back positive for arsenic. And so they went ahead, and DMSA is actually Sexamer. It's FDA approved for lead poisoning, but we also use it for arsenic poisoning, as I talked about last year. And so they went ahead and put people in arsenic poisoning. But eventually they put together that there were some other things going on, such as sort of the severe alopecia. And the thallium diagnosis eventually got made, but got made much later. Because when they heard about this cluster of symptoms, severe peripheral neuropathy, again, just a heavy metal urine screen got sent off. That did report actually a couple of these people did have elevated urine arsenic levels. But finally, when they put together, hey, there was a bunch of alopecia, this hair loss that we're going to talk about in a second, is then they realized, well, actually, the main culprit here is these people are severely thallium poisoned, have, again, severe thalatoxicosis. And unfortunately, this diagnosis is a little bit delayed in making, just because there was so much focus on, cluster of symptoms, heavy metal poisoning, let's rule out heavy metals, and just a generic heavy metal screen initially was ordered. But it was really this alopecia, this hair thinning that you see. It's just so pronounced in thallium poisoning, both again in those fictional descriptions by Agatha Christie, as well in some of those sort of mass exposures, and even in Dr. Qazi's Iraqi publication. But this is actually this initial patient 0 right here. When they evaluate him, you see this severe sort of hair thinning that goes on. Something that's also pretty unique to thallium poisoning, if you look at the hair roots through this oxidation process, as you can see sort of these really specific dark roots that appear. And this is actually several months later, at 6 months follow-up, that you actually see once he's over his thallium poisoning, thankfully had survived it, sort of returned to sort of his baseline, sort of I guess hairstyle would be. And then, how did they figure out what's going on here? Well, when the Poison Center at Indiana University, where put this together, is they did this impressive epidemiological sort of forensic evidence, and they finally decided that it was probably actually from 2 coffee pots, and they were finally able to sort of confiscate 1 coffee pot, test it, and sure enough, it did have arsenic in it. Incidentally, and this is what was really fascinating, was able to talk to Mark Kirk about this a couple of years ago, is that the second coffee pot that they suspected had thallium disappeared. And they never actually figured out the culprit from this. And so to date, sort of no arrests have been made about this. But I like this report because it does show that there are the potential for mass exposures even here in the United States. And when you look at everything I've really presented up to this point, it's really, thallium is really being used for malicious intent. This is a little bit different than the arsenic case I was talking about last year, where particularly in Bangladesh and Eastern India, there's a lot of sort of cross-contamination in well water. And you can see sort of some accidental arsenic poisoning. And really, I think when you look through the literature and look through the news articles going out there, is again, most of the thallium cases that we come across it's either someone that's trying to hurt another person. And actually, as I was putting this talk together, this showed up on my news feed. I don't know if anyone saw this, but there was a freshman college kid at Lehigh University that just got caught. He was actually trying to thallium poison his college freshman roommate. This is sort of an ongoing sort of news article we're getting more and more information about it. But he was actually putting thallium in his roommate's food. And so we talk about thallium is, like several heavy metals, is it was used historically to treat syphilis, gonorrhea, tuberculosis. I think we see this, quite a bit with a lot of different heavy metals that are out there. Thankfully, it was sort of household banned in '65 and absolutely banned even for commercial use in 1972. And really after that, you see sort of big drop off, particularly of accidental thallium poisoning. But again, you just see it repeatedly throughout the world, involved in suicide, homicide. And then incidentally, it's shown up mixed with a lot of illicit drugs. There's actually been reports out of both France and Iran that have both had thallium had been or heroin's been cut with thallium. Really sort of an unexplained, we still don't know exactly why this is happening. I'm going up there, but again, cluster of cases of people become thallium poisoned after abusing heroin. And, if anyone again heard my talk from last year, so I really just like going to the history of this, and there's several, great thallium poisoning or thallium, I guess, marketing campaigns out there, Rough on Rats, and Rough on Rats apparently was sort of a catch mark phrase for thallium poisoning out there. But, thallium, it actually can be dermally absorbed, also has very strong, absorption from our GI tract, doesn't really have a very high endonomic reservoir. The organs that does tend to sort of concentrate the most in does tend to be the liver, intestines, and kidneys. And I do want to focus this on the intestines here just a little bit. One of the great things about giving this talk and being a toxicologist is, we can never actually talk about any kind of poisoning without at least talking about toxicokinetics. But there really is a point to this, particularly, I think, when it comes to a lot of the challenges in diagnosis. Because thallium in the first 4 hours, particularly from the GI tract, is sort of rapidly absorbed, distributed throughout blood. But this is the key part right here, is this next part. It's the CNS distribution phase. Because over the next 4 to 48 hours, and probably over the next 4 to 24 hours, really, is when thallium is being absorbed both in the central nervous system, but also the peripheral nervous system is here as well. This is really where it's distributing to a lot of its, in-organ effects, if you will. And we're going to come back to this when we actually start talking about some of the different treatment options we can do. And then the elimination phase starts around 24 hours. And thallium is actually really fascinating because it's constantly being, excreted back into our GI tract into being then reabsorbed from our GI tract. And we call this sort of interhepatic recirculation, meaning that, thallium gets in our blood, gets dumped back in, and the body keeps reabsorbing it. Again, this is actually going to be very important when we talk about some of our different treatment etiologies that goes along with it. And ultimately, thallium, ends up being excreted both in the feces and within the urine. When we talk about heavy metal poisoning, exactly how they're working on the pathophysiological level this is where I think we lose a lot of people. And I'm going to at least try to some way to at least simplify it. And, at baseline, I'm an emergency physician. So I like to try to simplify things as much as I can. And really what it comes down to is the body gets confused between thallium ions and potassium. And so enzymes that are very dependent upon potassium for normal function get disrupted when you have a large thallium burden. And the type of organs that are going to be very affected by this are going to be sort of organs that have sort of rapid mitosis, such as sort of some of your hair follicles, as well as your nervous system, both your peripheral nervous system and your central nervous system. And so you can also, because our muscle tissue is also very dependent upon potassium for depolarization, as well as thallium can sort of interfere with sort of a lot of muscle problems. And something that's really interesting about thallium, and it bears mention right here, is that it does tend to get your peripheral nervous system first and really likes the long fibers of your peripheral nervous system. This is one of the reasons why one of the first clinical things that you see with thallium poisoning is really severe painful neuropathy, because these long nerve fibers, going down your legs, are inhibited in this dying backs or Wallerian degeneration pattern that we learn about, and a lot of impressive demyelination that you can see, just causing severe painful neuropathy, which is, I think, unique to when you read about most of these thallium cases. In preparation for this talk, I was actually lucky. There are just multiple experts, both the United States, internationally, in addition to being able to talk to Mark Kirk and Dr. Causey about this. Cynthia Aaron out of Michigan, incidentally, has had several cases of thallium pop up. And with their permission, I stole this slide right here because I'm more of a visual learner. And so I think about thallium, this is really what I'm thinking about, is it's interfering with, essential enzymatic processes. It's causing this myelodegeneration causing that really painful dying back axonopathy, leading to that painful peripheral neuropathy, causing a lot of alopecia here as well, and just a lot of cellular damage at sort of the microscopic level. Something I haven't mentioned up in this point is that you can also form Mies lines. And so Mies lines are actually sort of non-specific to a lot of different heavy metals, including arsenic and antimony, but you can also see it in thallium poisoning. I have some pictures of this coming up here in a second as exactly what Mies lines are. And again, I just sort of as a break here before I go to another section of talking about thallium, is I pulled this as actually a case report that actually came out of Baltimore. This is just a 42-year-old woman showed up, and really with these very non-specific complaints, abdominal pain, abdominal distension, actually had a lot of constipation. Look here, just this really unexplainable, idiopathic, really painful peripheral neuropathy. And what's just, again, fascinating about this case, just emphasizing again and again challenges in these diagnoses. It took them 35 days before they finally put this together after they'd already ruled her up, worked her up for arsenic poisoning, thinking they'd already excluded heavy metals, and then finally went back and they still cannot figure out why there was such a severe peripheral neuropathy added on a thallium test. Again, I'm hoping to sort of make this a common theme as I go forward. And so we talked about a lot of sort of the clinical symptoms you see. Certainly alopecia, and that alopecia, particularly in that photo I saw earlier, can be pretty impressive. And again, alopecia is this hair loss, hair thinning. Most of the time with thallium poisoning, actually what you're seeing is pretty severe constipation. there are a couple of case reports out there of people getting diarrhea, but usually it's actually the abdominal symptoms of obesity is actually pretty profound constipation. And this can be one of the ways we could potentially sort of try to tease this out as different from arsenic poisoning because there's so much overlap. If you remember, one of the initial symptoms of acute arsenic toxicity is actually something we call rice water diarrhea. It's just profound, very, very watery diarrhea. And that's just something you really just don't see with thallium poisoning, which you usually do not expect to see with thallium poisoning. Somewhere around 48 hours, you're going to start seeing that really painful peripheral neuropathy. And that peripheral neuropathy, again, is, I think, is one of the big clues that just shows up. Because you really see this, throughout all these cases of arsenic poisoning, both in that Iraqi case studies as well as another sort of case series I'm about to show. And then you can also get, incidentally similar to what I'm about to talk about with organic mercury poisoning, is you can get some ocular deficits as well, and then certainly some memory and cognitive deficits. And so again, symptom progression, things that we've actually talked about here before, personality changes, painful neuropathy, alopecia that goes along with this. This is a picture of mesalines right here. This is decreased keratin formation across your nail beds. Again, it's something that we would expect to see with arsenic poisoning. You can see this antimony poisoning, potentially selenium as well, but absolutely with thallium poisoning. And this is actually a video. I'm not sure the whole thing's for time constraints, but what's interesting is that was actually a video that Dr. Kazi shared with me that was actually made out of Syrian refugees in North Lebanon. And it's sort of a public service announcement they put together, just trying to warn people about sort of symptoms of thallium toxicity. And by warn people, I actually mean warn medical professionals, just for this potential of these marked thallium poisons that was being seen in both Iraq, as well as potential in Syria for multiple thallium poisonings, and also in conjunction with these reports of ISIS out there as looking to acquire thallium. This is actually a case series as well as I put together, or excuse me, I stole from the literature. This actually comes from a Taiwanese case series of 14 patients, and these were mostly actually family members that ate contaminated bread with thallium. This is also thought to be a malicious importance or malicious intent, excuse me. And again, what you see right here is just this 100%, all 14 of them really came in with really painful extremities, as well as the alopecia. And really what I'm trying to impart when I talk about thallium here is pattern recognition, which is sort of, painful neuropathy, mental status changes potentially, but also alopecia. And so if you do identify thallium poisoning, what are your treatment options? And unfortunately, they're extremely limited. When I was talking about the toxicokinetics and particularly elimination kinetics of thallium, is I talked about this interhepatic or reabsorption that is excreted in the GI tract and then being reabsorbed. And one of the things that we would actually do that's pretty available to almost all healthcare facilities is to give someone activated charcoal. And activated charcoal is just, I think it has this like really cool name as, we did something to activate it, but it's really just charcoal that has all these spores in it, these holes in it, has a huge surface area, and it can just bind a lot of compounds. And it's thought that this can actually hopefully interfere with this constant reabsorption of thallium while it's in the GI tract. And there actually have been some rat models out there that have showed when activated charcoal, that's what AC is, abbreviated here, given twice a day, is it can actually sort of increase the elimination through the feces actually of thallium poisoning. I don't want to spend too much time on potassium. If you read sort of textbook chapters, maybe some older review articles, this had been promoted in the past, that just knowing that the body sort of gets confused potassium with sort of these thallium ions. If you give a whole bunch of potassium, could you liberate some thallium and allow the kidneys to excrete it? Potentially. But I think our bigger concern, as we've started thinking about this more recently in literature in the last 2 to 3 decades, is that if you're sort of increasing sort of the sort of total body burden of thallium and sort of increasing it more in the serum, are you exposed more to the CNS tissue? And so now most toxicologists, most people that practice try to stay away from using high dose potassium. And something that's also that gets talked about a lot in the literature is actually, can you use hemodialysis? And these are actually XTRIP guidelines, and XTRIP is actually, it's this very fascinating organization made of nephrologists, toxicologists, critical care physicians, and emergency physicians, and stands for Extracorporeal Treatment and Poisoning Work Group. And what they do is they put they try to do evidence-based recommendations about when should we dialyze certain toxins. And they actually have recommendations out there about thallium. And what they say is if you can get to a thallium poisoned patient in the first 24 to 48 hours, that really based off the low molecular weight, low volume distribution, and really absolutely no protein binding, is that they would go ahead and recommend hemodialysis. And you read the recommendations, they really say, there really aren't that great treatment options for thallium. It doesn't really respond to traditional chelators. And they really say the risk of hemodialysis is pretty low. So I do recommend going ahead and instituting early on. But this is the key part about why 24 to 48 hours. And that really goes back to when I was talking about sort of the absorption kinetics, the toxicokinetics, because of that second elimination phase, because we really think within 48 hours is most of thallium has been sort of mobilized into your neurological tissue. And after about that point, there's really probably not that much circulating thallium concentrations that are really amenable to hemodialysis that are out there. And I think this is really probably the biggest limitation if we're going to talk about hemodialysis with thallium, because it's going to be very unusual that we're going to get to a case with a high degree of certainty within 48 hours to say, hey, we should absolutely do hemodialysis. Certainly, if you know that someone had been maliciously poisoned, they show up right away, this would be something we would consider. But I think the delays in diagnosis really sort of challenge the use of hemodialysis. And then, finally, we conclude here with Prussian Blue. And Prussian Blue, again, historically has this fascinating origin. It was actually a paint pigment derived in Berlin in the 1706 or 1707. And the paint pigment is because it has this very profound sort of bluish color. But what was realized actually in the mid 20th century is it actually can form sort of this potassium lattice here. And if you give someone oral potassium blue, it will actually exchange potassium ions for a thallium ion inside your GI tract. And so instead of using whole bowel irrigations, we can actually give someone orally potassium blue and have them exchange out potassium with thallium and increase the elimination. Unfortunately, there are a lot of difficulties getting thallium blue, at least in the United States right now. There's a compounding company in California, McGuff, that's open from 8 a.m. to 5 p.m. And that's really who you need to contact and try to get it shipped to your state. Some state health departments actually stockpile this. In a severe mass casualty sort of exposure, this would be potentially something that you could contact the FDA and get involved in the strategic national stockpile. Or if you're having a lot of difficulties with McGuff, sort of getting there, expeditiously, this would also be something that through your state health department is you could contact the CDC through the REACTS program and sort of make a request for Prussian Blue. And then once Prussian Blue shows up, is actually when you would start discontinuing that activated charcoal I was talking about earlier, just because we believe that Prussian Blue, that lattice it forms, is much more efficacious in sort of binding at thallium and increasing its feces elimination. Another problem with Prussian Blue is it can sort of worsen constipation. So this would be something that you would want to give a bowel stimulating agent if someone's not actually already making stool, with the idea you want to sort of keep the gut peristalsis working so you can eliminate that thallium. Unfortunately, like with so many different things in toxicology, particularly so many different things with heavy metals, is human data is really lacking. And this is actually a 2004 really case series I saw where people are giving Prussian Blue. It was thought to have a benefit in these human case series, but as you can see over here, so in the outcome, there are also multiple other treatments that are going on simultaneously, which unfortunately can sort of limit any specific human level, I think, conclusions with it. That being said, it's still absolutely something that we would pursue, or we at least try to pursue if we had someone that we suspected or confirmed as being thallium poisoning. And then now I'm actually going to transition pretty quickly on to short chain organic mercury poisoning. And again, why did I want to talk about mercury? Well, same thing with thallium is I think there's also potential to use mercury, particularly organic mercury, sort of as a weapon of mass exposure. And incidentally, in 1978, there were some terrorists, if you will, they actually infused a lot of oranges that were grown in Israel with organic mercury. And this is usually going to be methyl mercury. And what's really interesting about why they did this is actually their Washington Post article from 1978 about this, is it got shipped to Western Europe. And unfortunately, after this, after multiple people in Western Europe became contaminated with organic mercury and started showing signs of organic mercury poisoning, is they stopped exports of Israeli oranges. This is really done, reading about this, or at least the way I interpret it as a way of sort of economic terrorism, because it really, I think, was a blow to sort of the Israeli economy at this time, just sort of this fear that they may have been contaminated with organic mercury poisoning. And I know many of y'all are bench scientists, and you may all be familiar with Karen Wetterhahn. It's a very sad case. She was in the late 90s, 1997, I believe, a Dartmouth chemist, and just unfortunately spilled a couple of drops of dimethylmercury, another organic mercury compound, on her skin, got dermally absorbed. And over the next really several months, just suffered severe neurological decline and ultimately passed away from it. And I think this also really shows just one of sort of the dangers about methyl mercury or organic mercury poisoning, particularly if it's going to be used for insidious purposes or mass exposure purposes, is the symptoms that you will get from this, maybe weeks, months following initial exposure, which is going to sort of institute another challenge to our initial diagnosis as to both sort of the etiology, what's going on here, but what potentially could have been the source. A very famous sort of exposure historically for toxicologists, you can't go through Tox Fellowship without learning this, is Minamata Bay. There was a company that was producing vinyl chloride, and the process of it dumped multiple things of methyl mercury into Minamata Bay. At least 121 confirmed deaths from it. But after that, really multiple, hundreds, not thousands more people were thought to be exposed. This number is thought to be sort of underrepresentative. And a lot from this too this is really where we learn about a lot of sort of the fetal implications, all of the teratogenicity of mercury from this Minamata Bay exposure. Unfortunately, in Iraq, we actually gave Iraq, was suffering a famine at that time, 95,000 tons of seed grain. We purposely actually put methyl mercury on there because it's a fungicide, and the idea that it was interesting that they were going to plant the seed grain. Unfortunately, it was ingested just because so many people were hungry. At least 400 deaths from this really sad exposure there as well. And then in the United States, at least EPA banned mercury from material paints in 1990. These are just pictures actually of Minamata Bay. This is a very gorgeous bay out there, but still a very sentinel event over those 20 years that methyl mercury was dumped out there. And I think, really sort of contribute to a lot of our understanding just of the dangers of methyl mercury poisoning. Mercury, there's so much fascination with it. This is actually a mercury fountain in Spain. What they have here, instead of water going through, this is actually elemental mercury that's being recycled. And I'm going to run through this really quickly because I keep saying organic mercury, and organic mercury is a specific type of mercury. So there's three types. There's elemental mercury, and this is usually actually what's in at least mercury thermometers. Thankfully, elementary mercury, if you ingest it, has almost no bioavailability. So if you ingest elemental mercury, it does not generally cross our GI tract. There is a concern that it can become vaporized. So if you inhale elemental mercury, it can cause your pulmonary bed and sort of cause sort of mercury type of poisoning. But at least if you ingest it, we generally would say, hey, this is actually not a big deal. Then there is organic mercury, and this is really going to be usually mercury chloride that's out there. Mercury chloride, organic mercury, historically we found in some diuretics, ointments. We still see it, unfortunately, show up a lot in sort of herbal products. It does have some GI tract involvement or GI tract absorption. And a big problem with inorganic mercury is it's really, a nephrotoxin. And a key thing is it causes sort of kidney damage, but also I put here eliminated via the kidneys. And this is going to come back when I conclude and talk about some of the challenges in diagnosis that we see with this. And again, that you see sort of in your renal failure with it. Something that's unique both to inorganic and organic mercury is sort of something called acrodynia. This is actually Pink's disease, and it's ought to be sort of a immunological response that you see here, particularly actually in children, sort of this desquamation, sort of the soles and the palms. But what I'm really focused on here is organic mercury. Usually this is methyl mercury. And methyl mercury is really dangerous because it's almost completely absorbed to the GI tract. But what's interesting about it is methyl mercury is really a pure neurological poisoning, in that it very quickly crosses the blood-brain barrier and then actually gets converted to inorganic mercury, but does its damage within inside our CNS tissue. Almost none of this is actually eliminated through the kidneys. And this means that if you're testing your urine and you suspect organic mercury poisoning, you're going to miss it, because almost all organic mercury here is actually eliminated through the feces. Something I don't have here is, in addition to going into CNS tissue, is organic mercury also gets concentrated within inside our red blood cells. And that's going to be important because if you actually do want to pick up the diagnosis of organic mercury poisoning, you really need to order a whole blood mercury test. Now, if you remember that slide I showed at the very beginning talking about testing for heavy metals, shows a urine mercury test. And so I think there's a lot of confusion there, because if you suspect organic mercury poisoning, and which is by far the most dangerous type of mercury poisoning, is if you order a urine test, you may think that you're evaluating a patient for organic mercury. But in actuality, you're not, because what you need to do is simultaneously be getting a whole blood mercury test. And I think this is one of the failures we've done in sort of communicating not just the general public, but also to sort of our medical professionals that we work with, that do not get lulled in a false sense of security with that sort of generic heavy metal test. Just because it says mercury, you're actually going to miss, I think, the most dangerous type of mercury. And again, the problem with organic mercury is the symptoms delayed weeks to months. Again, inside the CNS tissue, binds to enzymatic process, which are dependent on these sulfhydryl groups, and really decreases sort of the formation of acetylcholine. Acetylcholine is a very important neurotransmitter within inside sort of our neurological tissue. And it's really what, at least I believe, causes sort of the vast majority of the destruction of CNS tissue with organic mercury toxicity. And so what you see with this is just a lot of ataxia. You also get this really impressive visual field constriction where you lose all your peripheral vision and really just get very, small tunnel vision, movement disorder, salivation, tremor, and personality changes. Here are just more pictures of, acrodynia. Hat-making encephalopathy actually came from hat makers, because what they would use is actually mercury nitrate and just in the tanning process there. And what happened is this would get absorbed, would become organic mercury, and something called Hatter shakes or Mad Hatter disease actually came from this. We see speech problems, emotional instability, hallucinations. And in fact, in Connecticut in the 19th century, the city of Danbury apparently is one of the hat-making centers of North America. And people came in these really impressive mercurial shakes and this sort of encephalopathy, and at least the 19th century became called Danbury shakes from organic mercury poisoning. And from this is really where I think we got good descriptions of something we call mercurial tremor. And the point of mercurial tremor is you'll get this very worsening sort of tremor in your extremities. And the more you try to control it, the worse it gets. It's really interesting. When people sleep, it actually goes completely away. When you get distracted, your tremor will go away. But when you start focusing on it, it will get worse and worse and worse. That's something that I think that's very unique actually to organic mercury or mercury neurotoxicity. And it's also from this Mad Hatter disease or this, Mad Hatter encephalopathy is closely associated with erethism, which is really profound personality changes, decreased self-confidence, depression, apathy, and almost profound shyness that goes along with it. I pulled this actually from, comes from these, from Dr. Hunter's London case files. And if you ever read about sort of history of organic mercury poisoning, is everyone talks about this because in the 1940s, Dr. Hunter did such great depictions of what sort of organic mercury poisoning looks like. And I just sort of want to highlight some of what his observations were, which is really what we're seeing. This is actually a gentleman that he took care of that actually was involved in the manufacture of seed dressings. Again, mercury is being used as a fungicide. Comes in the severe peripheral neuropathy, the sort of paresthesias that he's feeling. And they were actually initially thinking this was actually more of neuropathy. And what this is actually not really peripheral neuropathy. This is more central declines in your acetylcholine concentrations. Then again, notice I'm studying this at gait. Speech became thicker and slower, and his vision became worse. What's really fascinating is what Dr. Hunter did is on the left, these are actually plants that were pre-treated with mercury nitrate as a prevention against fungus, and here are plants that were not. I just found this really interesting how he's even trying to explain about why were a lot of these plants pre-treated with mercury nitrate. And what you see here, this is actually this gentleman, a picture of it. And when he's sort of staring off into space when he describes it, he's really unable to communicate, has severe saliva, sort of this impressive ataxia. He's unable in this point to even stand up straight. I'm too much of a Puritan here, so I put a blue box there over his genitals. And then Dr. Hunter also did some, animal dissections. He actually purposely poisoned rats here, and he's showing severe demyelination of the posterior spinal cord after sort of organic mercury poisoning. These were actually sort of his depiction of what the visual fields were for this gentleman. You see here is what he's actually seeing, and out here is just severe loss of peripheral vision. And so we talk about tunnel vision. This is very specific tunnel vision that Hunter's describing. And this mercurial tremor too, he also has all these handwriting samples that here he's actually, this is this case prior to being mercury poisoned. And here you see right here with this mercurial tremor, just unable to have sort of any control of upper extremities, sort of as this case goes along. And then finally here, several months later, is after this patient got over sort of mercury poisoning, was ultimately able to regain some of his sort of upper extremity control. And what Hunter does in these London 1940 case centers is again just really emphasizes about sort of the delayed onset with this, that this patient here really just became, over the course of several months, just progressively worse. Again, I think just one of the difficulties of making a diagnosis for organic mercury poisoning. And unfortunately, when you start talking about treatment for organic mercury poisoning, we just don't have good options out there. We have standard chelators, and I took this slide actually from my arsenic talk from last year, because when it comes to arsenic, we know a lot more about chelation therapy than we do with mercury poisoning patient. But our mainstay of treatments is BAL, this is British anti-leucite, otherwise known as dimercaprol. DMPS is actually not available in the United States, and DMSA, dimethyl succinic acid, colloquially known as Succimer, that's out there. And last year we were actually, the center was lucky enough to have Dr. Kosnick came and also talked to us about arsenic poisoning. And Dr. Kosnick is actually is one of the international experts, and also in chelation mercury poisoning here. And this is one of his papers from 2013. And really, this is actually talking about chelating inorganic mercury poisoning. Because what they found here is inorganic mercury poison, because it stays in sort of the serum a lot longer, it's going to be a lot more amenable to being sort of mobilized by traditional chelators. And what he found is in this is a rat study, that in this group of, I guess each cohort here had 8, that DMPS, this is a chelator, again, that's not available in the United States. There was actually significant sort of improvement in the amount of mercury that was found when using DMPS, and a little bit with DMSA, which would be Succimer. The problem is we just don't have that kind of literature or that experience when it comes to organic mercury poisoning. Again, because so much of organic mercury is being mobilized very early on in the CNS tissue into sort of our erythrocytes. And when you do talk about what literature out there, it's extremely limited. This is actually a 1978 study, again, looking at rats. And what they did find is these were rats that were poisoned with methylmercury, so this is organic mercury. And then 4 days later, as they were giving BAL, D-penicillamine, and DMS here is actually Succimer, dimethyl succinic acid, excuse me. And at least in this one 1978 study, when rats were giving Succimer 4 days after their exposure of methylmercury, there was significant decrease in the concentration of mercury exposure. And because of really this one 1978 study, is at least what toxicologists say is when it comes to organic mercury, if you suspect it, try to get it on as early as possible. And we'd actually use Succimer at this point, because Succimer tends to be a very safe chelator, has sort of a low side effect profile. But to be frank, we really just don't know if it's really going to have, that much benefit with organic mercury poisoning, just because we really don't know about how much sort of benefit you're going to get with mobilizing sort of your CNS mercury concentrations. One thing I will conclude with why we do use Suxmer and not British anti-leucite is because when it does mobilize mercury tissue, Suxmer will also cross the blood-brain barrier, and it can potentially also give, a lot of protection there. There's a thought that actually BAL does not have that same crossing blood-brain barrier, and may, if you liberate a lot of mercury poisoning, could you also actually sort of increase the CNS exposure to mercury if you use BAL? And one of the reasons why we try to say, actually, when it comes to organic mercury poisoning, is we try to stay definitely away from BAL and probably try Suxmer, although again, the evidence for this is extremely limited. And so I know I'm here out of time, so I'm going to conclude here with really my final thoughts. Is that I think there is, with both organic mercury poisoning and thallium poisoning, there's both historical basis, but there's also potential for future threats with thallium poisoning and with organic mercury poisoning. It is very often overlooked. And the thing that actually I think gives me the greatest consternation is there's just a lot of confusion about what usually goes into a heavy metal screen. Because if you're going to work up thallium, and thallium is going to overlap a lot with arsenical poisoning, is you need to order a specific urine test looking for thallium. And if you're going to consider organic mercury poisoning, do not be lulled in a false sense of serenity, because your heavy metal screen is looking for mercury. That heavy metal screen is looking for inorganic mercury poisoning. And again, this is that same heavy metal screen that I talked about in the beginning. And here's just another one. These are just common commercial assays are out there, again, just showing that our usual heavy metal screens are looking for urine arsenic, cadmium, lead, and mercury. You're going to miss thallium, you're going to miss organic mercury poisoning. And so it really comes to pattern recognition. And hopefully I've really sort of braided this into you guys here, and you got somewhat as excited about this as I do. But with thallium, painful neuropathy, alopecia, measles, lethargy, ask yourself, could this be thallium poisoning? If you're considering it, order a specific thallium test. And organic mercury, again, personality changes, ataxia, visual field disturbances. This is sort of where I think the center, this CounterACT Center, has such a great benefit, because it's really promoting the idea of looking for constant clusters of these common patterns here. That's why I'm so actually proud to be part of this center. And I'd be remiss too if I didn't sort of advocate out there for both the Alabama Poison Information Center, because we are constantly on the lookout for constellation symptoms, looking for mass exposures for not just arsenicals, but thallium and mercury poisoning, as well as the Alabama Department of Public Health. And I am going to go ahead and end right there. And thank you very much, everyone, having me.
Thank you, Dr. Rushton. We have quite a few comments and questions, so we'll try to get to as many as possible. So the first question is, the person asked, I remember that Mr. Alexander Litvinenko was assassinated with radioactive polonium, was initially diagnosed with thallium poisonings. Can you comment on the similarities between thallium poisoning and radiation illnesses?
Yeah, so that's sort of a great question. There can be a lot of sort of overlap with it, particularly because when it comes to both radiation poisoning and heavy metal poisoning, is they're really hitting all the organ systems in the body. Because we talk about thallium poisoning, sort of arsenical poisoning, we're talking about inhibition with key enzyme groups. And certainly you can get that with radiation poisoning, but on radiation poisoning, you also just get sort of cellular dysfunction at sort of a very microcosmic level. And so when you think about heavy metal poisoning and then radiation poisoning, it's not really just specific one organ that you're looking at. It's really sort of a multitude of organs that goes across. And then particularly, I think one of the sort of confounding factors that you get with radiation poisoning is because it prevents mitosis, is you can get profound sort of alopecia as well from sort of initial radiation poisoning. It's why we see this a lot, with both chemotherapeutic agents, but also with people undergoing sort of radiation for different cancers out there. And you'll see that a lot actually with thallium poisoning, again, is sort of that alopecia that goes on as well. And again, with radiation poisoning too, is certainly possible to see a lot of peripheral neuropathy.
Another question, what is the major source of thallium pollution or contamination?
Thallium can be found in a lot of volcanic ash. What I am really interested in sort of when I was doing sort of my reading, putting together this talk, and then again talking to a lot of people out there that have seen much more thallium cases than I have, I'm really impressed that as opposed to arsenic poisoning, is usually when we're talking about thallium, it was done for insidious purposes that's out there. So even though it's found in volcanic ash, we're not really seeing, at least right now, sort of those mass contaminations that we're seeing in sort of Eastern India and Bangladesh with the water poisonings out there. As I'm sort of scrolling through the slides here, I did see someone is actually talking about here in India, there's actually hundreds of people sickened with thallium died with the source being unknown. And so that's actually a great point that at least I'm able to see in the comments. I don't know if anyone else is. And then it's, very interesting because you read about these poisoning cases, particularly in Syria and Iraq. And even the case we found that small Midwestern towns, when multiple people are exposed to it, is the source is suspected to be, again, malicious, but often sort of the exact source, what supply did it come from, remains very ambiguous, in multiple cases unknown.
Well, I know we're at the top of the hour, so I just want to thank you again for speaking. We really do appreciate your time. And I want to thank everyone who signed in and watched and attended this grand round.